Okay. Good morning or good afternoon. Hi, everyone. Thanks for joining. We're going to give everyone some time to kind of funnel in here. I know we're right at the top of the hour, and we'll give everyone about a minute or so, and then we will get started with introductions. We'll lay out our agenda and just kind of walk through the format of how this will go for the next hour. All right, so we'll get started now with some introductions. The attendees have kind of slowed down a bit, but others will begin to come in. So first, I just wanted to say welcome. Thank you all for taking the time to spend with us this morning or this afternoon. Hopefully, we're able to answer some of the questions that you guys have around Medicare Part B. We're going to start off with some introductions. My name is Charlie Brez-Nicki. I'm a registered nurse, one of the directors at SimiTree on the clinical operations team. And over the next hour or so, we're really hoping to go over some of the elements that you might be able to use as part of Medicare Part B to supplement the services. So we're hoping we will talk about hospital at home, Part B, and therapy, as well as palliative care. We want this to be an interactive session. So myself and the other panelists will give a bit of an intro on who we are and each of those areas that we had just discussed. But then we want to open it up to answer any questions that you may have about each of those. I'll be monitoring the Q&A part, so feel free to enter them in there, and then I'll ask them out as they arrive. So just a bit of a background on myself. Like I said, I'm a registered nurse. I've been with SimiTree for 6 years, helping agencies out with the COPs when they first changed in 2018, then moving into PDGM. Recently, it's been around BBP, plus all of the waivers around COVID, how to adapt and how to adjust to those. I spent a lot of my career in quality and compliance with several home health agencies. I was a field nurse and a manager, bringing a lot of that experience there right from the field, as well as that quality and compliance aspect. So at this point, I'm going to hand it over to my panelists so you can hear a bit more about them. Then we'll talk about each of our areas. So I'm going to hand it over to Maureen to introduce herself.
Hello, and good morning or good afternoon, depending on what time zone you're in. My name is Maureen Kelleher. I'm also a registered nurse by background. I also have an MBA in healthcare administration. I have been in hospice and home health, or hospice and palliative care actually, for about 26 years now, doing pretty much everything in hospice that you can imagine, and also being a director of quality, compliance, and education for a hospice that had, we're involved in 3 states and had 5 different programs going. I've also been on the regulatory committee on NHPCO, and I am also now on the Palliative Care Advisory Council. So lots of experience. I've also run a family practice for 5 years, which also coincides with Part B billing and palliative care. So it's been a great experience to help with getting people started with palliative care and getting their programs off and running. And I will now hand it over to John and let him introduce himself.
Great, thanks, Maureen. And good afternoon, everyone. Thank you for joining us today. My name is John Rabia. I am a director on our operations consulting team here at SimiTree. I am a doctor of physical therapy by training with an MBA. I've worked in the post-acute space my whole career, going on 20 years now, from patient care all the way to C-suite positions over operations and quality and compliance. So been with large hospital-based systems, standalone systems, kind of been all throughout the space, and have dabbled in the Medicare Part B therapy milieu that we'll be talking about today a little bit. So excited to bring some information to you and to answer any questions you may have today. So thanks for joining us, and I'll kick back to Charlie.
Great. Thank you very much, John. So at this point, we'll go through a bit of hospital at home, Part B and therapy, as well as palliative, just to make sure that you have an understanding of that. You may know about it already, but we just wanted to kind of lay that groundwork there and then opening it up to any questions. So hospital at home, really as an overview view there is really it kind of was pushed into the front with COVID, some of the waivers that CMS had pushed forth. And what this allows is patients are able to receive hospital level care in the home. So that rather than being in that brick and mortar facility, they were able to get that care at their home. There were some requirements that had to be met. They must have had an in-person physician evaluation and screening prior to receiving that care at home. And then once they're admitted into the program to receive that care at home, they must have an evaluation by a registered nurse at least once a day. And this is able to be done in person or remotely. Really, it depends on what the patient's plan is, as well as the policies of the organization providing the hospital at home services. Additionally, there are some requirements as to quality and safety data that CMS expects to be reported out as part of this program. So far, it showed some pretty positive outcomes in patient outcomes and patient satisfaction rates. So it's still a growing area of healthcare, but definitely one that CMS is likely to explore a bit further as we move into the future. So in addition to hospital at home, there is palliative care. And I'm going to hand it over to Maureen to do a bit of a summary and just an overview of what that entails.
Thank you, Charlie. So palliative care was separated out from hospice a while back, and it is a subspecialty under the American Medical Association. Palliative care is symptom management, and the original intent was to capture patients earlier in their disease progress to where symptoms weren't necessarily being managed along with treatments or curative treatments for the disease itself. So the hope with palliative care is you catch these patients earlier on in their diagnosis, you keep their symptoms managed, and in many studies has proven that not only do the treatments work better in cancer patients, so those patients will sometimes come into remission faster, stay in remission longer, and don't need other services for quite some time. So a palliative care program is not hospice light. So it is providers treating symptoms during curative care, and symptoms that are caused either by the disease or by the treatments for those diseases. So it is providers managing those symptoms, managing the medications, and complementing the specialists or the primary care doctors who are taking care of the patients and taking care of the diseases themselves. So it's not in place of hospice, it's not in place of home health, it's not in place of your primary care. It's in addition to, and it provides a safety net for patients who sometimes the symptoms aren't as well managed. So that's a high level overview of palliative care. One of the other Part B service lines that you can have that help augment care for patients is Part B therapy. So I'm going to let John, because that's his specialty there.
Great. Thanks, Maureen. So Medicare Part B therapy, a lot of times lately, it's being referred to as outpatient at home, which I think can be a little bit confusing, but I'm going to refer to it just as Medicare Part B therapy. The reason they call it that is because, you know, Medicare Part B is the part of the Medicare program that typically pays for outpatient services. And if you were to receive physical therapy as a Medicare beneficiary in an outpatient PT clinic, they would be billing your Medicare Part B benefit. A lot of the outpatient clinics, brick and mortar clinics, have figured out that you can provide those services to a patient in their home, and very often, particularly with older patients, although they might not formally be homebound as we would understand in the home health sense of the word. They might not be homebound, but it's still difficult for them to get into a clinic to receive their therapy. So these clinics have started providing their therapy services in the patient's home and billing Medicare Part B for those services. There's even a few organizations or companies where that is their entire business model, is doing therapy in a patient's home and billing it to Part B. The really interesting thing, I think, in home health is that there is a statute in our conditions of participation, our home health conditions of participation, that state that home health agencies can provide Medicare Part B services to a patient in their home to give them physical therapy or occupational therapy or speech therapy. I promise I'm going to try not to slip up and be PT specific. This applies to everything, but because I'm a PT, that tends to slip out of my mouth. Anyway, so outpatient therapy services in the patient's home under Medicare Part B. So you as an agency could do this now. It is a service that you can provide to a patient after they're finished with their traditional home health stay, at the point where you would discharge them because perhaps they're no longer homebound, or even perhaps a patient who is referred to you for therapy services. And when you go out and do the eval, you find out, oh, they're driving around all over the place. They're not really homebound. You are able to actually provide services, therapy services to this patient under the Medicare Part B benefit. So it's a whole other realm of service that you can provide under your home health license without having to submit another 855 or anything of that nature. We have had many clients, more and more each month, it seems, who are starting to explore and implement these services, particularly as they look at how best to provide therapy services to their patients under PDGM, where we're being much more careful and thoughtful about how we utilize therapy services, and it might not be doing quite as many visits as we normally would, maybe discharging patients a little bit sooner than we would. This is a way that we can continue care for those patients and still offer them that service in their home. So it's not something that you would do at the same time as your traditional home health episode. You would have to be totally discharged from all other services before you initiated this, but it is an option for you. And the paperwork is substantially easier than under home health. The regulations are a little bit more lax. All around it is a little bit of a easier way to provide services for your patient. Again, assuming that they're not homebound and they're not on their traditional home health episode of care. So that's a very quick high-level overview, and excited to hear what questions you may have to clarify even further.
Great. Well, thank you very much, John and Maureen. We do have several questions coming in. I just want to encourage everyone else, if you have any as we're going along from that overview that you had just received, feel free to enter them in. We'll try to get to as many as we can over the course of this session. So the first one came in asking about EMRs and Part B outpatient, and asking, can you recommend a certain EMR with billing capabilities for Part B outpatient? This would really be for John. I mean, I'll say off the bat, at SimiTree, we're really EMR agnostic, but if there's certain things you would want to look for in an EMR, if you're able to give any insights there.
Yeah, so this, I'll be very upfront. If you are using a home health specific EMR, and I think I saw in the question, somebody said that they've been looking into this and it's been a challenge, and that is very much the case. Home health specific EMRs really aren't set up for this, unfortunately. Some of them have a little bit more flexibility in terms of being able to build it out for you. It's probably going to be a workaround. The best luck that we've had really has been with our hospital-based clients who are using EMRs that have an ambulatory care module that would be where they're running their outpatient therapy clinics out of. They're able to kind of build out a division of that to be used by home health because it has the documentation requirements, the billing flows through a little bit easier. So if you happen to be a hospital-based system on an EMR that has ambulatory care functionality, that's probably your best bet. If you're not a hospital-based system, if you're on a standalone EMR that's really kind of tailor-made for home health and/or home health and hospice, typically what our clients have had the best luck doing is having a separate EMR that's meant specifically for outpatient therapy. I know that probably is a cringe-worthy response. You're probably wincing. That probably wasn't the response that you wanted. But what I can say is that these EMRs are typically web-based. They are much more affordable, especially for the number of licenses or the volume of patients that you'll probably be seeing. It's pretty affordable. The setup is pretty easy. So to have that separate EMR running is a little bit less of a headache than what you might be imagining if you've ever gone through a full-scale agency go live on a new EMR. So again, if you're hospital-based, see if you have access to an ambulatory care module that you can leverage. If you're not, then you're probably going to want to look at a outpatient-specific EMR to use for those patients.
Great. And pretty much the same thing for palliative care, except palliative care is set up like a physician's practice, clinical group setting. So you have to make sure that the EMR system, whatever one you use for palliative care, when you're doing it under Part B, that it has the ability to do your MIPS quality measures. It's one of the things that I see is kind of not in some of the ones that are multi-purpose. Is you need to make sure that there's an easy way to get your MIPS quality measures, that you can do your Part B billing, that it hopefully scrubs your documentation to give you the best E&M coding for the documentation that the provider has given, and that that by the time you reach some parameters Medicare has set for having to provide quality reporting, that it has the ONC IT certification, and that it has a patient portal where they can request appointments, hopefully pay their bills, see their lab work, all of that. So there's a little bit more on the palliative care side, but again, just like John said, it's usually a little less expensive than the hospice and home health programs and software out there. And the ones that are more successful are the ones that have a separate one for their palliative care practice.
Great, thank you. I think that those were some great answers. Hopefully that we answered that about the EMR. We have another one in here about asking if an agency charges from Medicare Part A home health therapy, is a new referral from the provider required to admit the patient to Medicare Part B therapy?
So it's a yes, but it's far less onerous than what you would think for home health. Typically, all you need, anything that would suffice, is as you're calling the physician to report that you're discharging your home health episode, just get a verbal order to do Part B therapy in the home, and that will suffice. The paperwork requirements are way less. You don't need a face-to-face. You don't need to have a history and physical, or you don't need to have really any referral documentation except for the verbal order for that. So that's all you need, and you can usually kill two birds with one stone as you're calling to report the home health episode discharge.
Okay, great, thank you. We did have one for Maureen, really about palliative care, really asking, why should I start a palliative care program, and what gets reimbursed under it, if anything?
Okay, so palliative care, besides being the right thing to do for patients who need help with symptom management, when it is set up correctly, set up under Part B and done as a provider house calls program or clinic setting, you really get to help these patients, especially when it comes to goals of care, quality of life conversations, advanced care planning. What is it that these patients really understand about their disease, and at what point do they think enough is going to be enough? And it may take some time to get there. If you wait until they're inpatient in the hospital and they pull in a palliative care team in the hospital, chances are they're already hospice eligible. The treatments aren't working, they're pretty sick, they're in an acute crisis state, or they wouldn't be in the emergency room or the hospital. So you want to be able to provide a service for these patients before they get there, so they can make good decisions for their healthcare without being in a crisis setting. And it also provides time for families to get on board with what the patient really wants, instead of trying to make these decisions at the end. What does get reimbursed under Part B for palliative care is your physicians, nurse practitioners, PAs, and licensed clinical social workers. So if you haven't already set up a palliative care and you're thinking about it, or you're already doing it, but you're really doing hospice light, if you're struggling with reimbursements and actually, breaking even or having a little bit of a profit margin, it's because you have a lot of people in there that you can't get reimbursed for. It is either the coding and the documentation, or you have nurses and aides and social workers and chaplains who are involved in palliative care. The only ones you're going to get reimbursed for are your doctors, nurse practitioners, PAs, and licensed clinical social workers. And they get reimbursed because they have their own NPI numbers and they can bill Medicare for their services. And it's more of a psychoanalysis, support groups, and hypnosis and whatever under a clinical setting for these social workers. Hospices can use medical social workers. They don't have to be licensed clinical, so you can't bill for them. So that right now, that's what we're seeing. You can get paid for advanced care planning. You can get paid for reviewing medical records and talking to their primary care and their specialists. So there's a lot of codes you can use, but you have to make sure the documentation supports those codes.
Great, thank you very much. So we did have one comment here about a hospital at home program, was really asking, is it only for hospitals, as in can only hospitals participate in the hospital at home program? And the easy answer is no. However, if an agency not affiliated with a hospital is going to apply to provide hospital at home services, they must work along with the hospital, and a hospital must accept responsibility for the program to meet the COPs related to that level of patient care. So if you're a home health agency, you're not affiliated with a hospital, and you're looking at this, consider the relationships you have with the local facilities in the area. Is this something that you want to partner up with them and work along with them in? Because there's a lot of other requirements and factors that will go into there about documentation, policies that a hospital must meet. So the easy answer again, no, but a hospital must accept that for that responsibility. And there was another question was regarding new referrals for Part B therapy. Is there specific referral codes that must be approved from Medicare, just like in Medicare Part A with the PDGM rules?
No, there isn't. And this is one of the parts of this that generally makes people pretty excited. There are no like questionable encounter type codes. In fact, coding in general is much easier. Typically the ICD-10 codes that you're going to use for Part B therapy are exactly the codes that we're not allowed to use anymore under PDGM. So it will typically be a code like abnormality of gait or generalized weakness. All of these codes that we've been really pulling our hair out trying to figure out, well, what's the etiology of that? We got to use something more specific. Under Part B, you really only need one or two of those codes. It's patient specific based on the patient need. But there is no such thing as like a questionable encounter code. And again, you typically are going to use those symptom codes that we've been trying to stay away from under a traditional Medicare home health benefit.
Great, wonderful. So kind of along those lines of coding for Maureen, what is evaluation and management coding? I think you had mentioned it earlier. And then what is the best way to code for palliative care? Is it by time or in some other method?
Okay. So evaluation management codes are the actual visit codes that doctors and clinics and house calls programs have built for decades. They are based on time and or complexity. The new rule that came out in 2021 for offices, for clinic settings, doctors' offices, is they can only choose one or the other. The codes that go for ALFs, facilities, and in the home, you can still do either or. It's probably going to change to being about complexity. CAPC and NHPCO all pretty much follow along the same idea that complexity is the better way to code for palliative care, because you could have a very high complex person that you go into, you walk in and you end up calling 911. By the time the ambulance gets there to take the patient, there's all these things going on and you're still doing your assessment, but you may only be in the house for 30 minutes. So if you're billing on time, you're missing that complexity component. And there are other codes that you can add to that visit to justify what you actually did in the visit. So you want to make sure that I always recommend to my clients to bill based on complexity. But then you have to understand how your providers have to document in order to justify that complexity. If you bill on time and you're in the house for an hour and an insurance company or Medicare asks for a copy of that visit note to justify the code you billed, and it doesn't say anything, how do you justify an hour in there if it doesn't really show the complexity? So in the end, you're probably using both complexity and time to figure out the codes. But I would stick with the complexity just because these are usually sicker patients. There's a reason they're in their home. They can't get to the doctor's office. So you might want to kind of follow up on complexity and provide that training. If you don't have it, find somebody like SimiTree who can provide that kind of training to your nurse practitioners and physicians about coding for E&M coding. Was there another part to that question? Did I get them all?
Yes. Yep. Good. Yep. I think you got them all. Thank you very much there. So our next one was about hospital at home. And this one asks, for hospital at home, are you typically working as a subcontractor for a pharmacy or hospital, or can you bill directly as well? So if you're going, there would have to be specific contracts in place if you're going to provide the services, maybe the nursing to a hospital. You would want to have that specific contract in place. But as far as the billing, all of the billing requirements remain the same as for those in patients. So hospital at home billing is the same as it would be for that inpatient side. So if you don't bill currently for any inpatient services, and this is an area you want to explore, you definitely want to familiarize yourself along with that to see what is actually required. What does your EMR that you have now even support that? What would you need to do to get that done? So that's something, if you're going to explore it, to have a look at what is required for that inpatient billing and making sure you have all the coding right to be able to bill for those services. But if you are going to work as a subcontractor with some of your staff providing those services, you want to have it clearly laid out as to what will they provide, how often, and how you'll be reimbursed, in what manner for the services, and how they'll document that as well, because they'll need to be compliant with the policies and the procedures of that entity. So just some things to keep in mind there, if you're looking to go down that avenue. So our next question was for John about Part B. Do you have to see a patient for a home health episode before transitioning to Part B, or can you just start Part B right from the start? And then there's a Part 2, but I'll ask that one.
Part one's pretty easy. You don't need to start off on a traditional home health episode of care. You can, if you get a referral for a patient who you determine is not homebound but does appear to have a skilled need for therapy, you can initiate straight off the bat through their Part B benefit. So that's pretty easy.
Great. So then the next one here was, do you have to complete any ongoing OASIS documentation, since you're technically billing under home health with any patients that transition to Part B?
This is another fun part of this. You do not need to do any OASIS for Medicare Part B. So our two scenarios, if we have a patient who was on a traditional home health episode of care and you're discharging them, you would do a discharge OASIS, a full agency discharge, and then you would initiate their Part B stay with a therapy initial evaluation, which just needs to have, it doesn't need to have the OASIS elements in it, just the therapy specific evaluation elements, which we can get into the specifics of it. It's very similar probably to whatever you're using now. What is their diagnosis, their history, their impairments, your goals, treatments, prognosis, all of that sort of stuff. But you do not need to do an OASIS. And then kind of tagging on to that, your treatment notes are just discussing the treatment that you do. You need to do a progress note at least every 10 visits, which is kind of similar to our 30-day reassessments. But so every 10 visits or sooner, you evaluate how they're progressing towards their goals with essentially a functional reassessment. And then another fun part of this is that your recertifications are every 90 days instead of every 60 days. And again, that recertification is not an OASIS recertification. It's just a reevaluation, essentially, revising the plan of care as needed, and sending that off to be signed by the provider. And the plan of care, by the way, doesn't need to be in a 485 format or anything like that. Not that home health does anyway, but so yeah, no OASIS. You do your initial eval, a progress note every 10 visits, and then recertification every 90 days.
Great. Thank you very much, John. So our next question that we want to ask about is palliative care. So to Maureen, if I have a palliative care program under a home health program and bill as home health, where can I have more information on how to bill Part B? I guess any kind of references or anything like that that may help out.
Right. So I would love to find out specifically, how are you billing it under home health? Are you already billing it to Part B and just your nurse practitioner doing a visit for symptom management? If you're billing it more like a home health episode, then you can find out under the Medicare CMS website for palliative care. You can, if you want to join CAPC, if you're already a member of NHPCO or NAHC, NOC, They all have resources, and you can call us at SimiTree, and we have several people who are experts in all of these different areas who can help you get the answers, and probably easier to talk one-on-one with the specifics of what you're doing than to answer a generalized question. But I also did see somebody ask about, can you do home health and palliative care? So if you have your palliative care program under Part B, you absolutely can do home health and palliative care. It's Part B, it's separate from the home health benefit. The patients can still get home health, which is the nice part about doing palliative care this way. They can still, you can still follow these patients if they go in the hospital and come home. If they have a primary care doctor, you work in collaboration with them, but when they're too sick to go see their primary care, you can go and see them in their home. But definitely you can bill Part A. And some of the Medicare Advantage plans right now are kind of tweaking palliative care benefit to include hospice and palliative care, which I'm still trying to understand how that really should work. But I've seen some of the Medicare Advantage plans try to incorporate palliative care and hospice, not fully understanding that hospice provides symptom management while you're at end of life, but palliative care is before you're at end of life. You have a serious illness that has symptoms that are related to those illnesses or the treatment. So I think I took care of 2 questions there for you.
All right, thank you very much. So our next question was around hospital at home. And this person asked, what types of conditions or diseases are best suited for hospital at home? So this is one that agencies will have to specify this. It is kind of at, after that initial evaluation, the screening is done. It's more than just having a look at the patient. It is also considering what is their home environment? Are there caregivers that can assist them if need be? How do they get their medications? What is their environment like? Is it safe for them even to return home? So it's kind of that fine line as to patients that need to be in an inpatient facility but could be managed at home. So patients who maybe have a chronic illness with an exacerbation of that disease that would warrant them being in the hospital, but possibly if they have an adequate support system at home to help them manage the disease, maybe it's a congestive heart failure that they're having an exacerbation of, and you're going to modify the medications that they're on. If they have an adequate support system at home, they may be okay in the home environment. However, that same exact patient who lives alone and does not have a support network, they're probably not safe being home. They might be best served in that inpatient facility. So it's a bit difficult to say specific ones, but I would think that those chronic ones, that the patients who have that, who would be safe in their home environment and have maybe had a disease for a while that they're trying to manage, may be more appropriate than those that don't have anyone around them. So if you're looking at that, maybe you have that program now, you're looking at the patients that you want to have at home, is do that full comprehensive assessment as to what is their network like, what are the resources available to them, and also is, if they had to go into that inpatient facility, how are they going to get there? How far is the facility from their home in the event of an emergency? So really is taking that whole comprehensive picture of the patient to determine if they're appropriate for hospital at home. Our next question was for John. So this was, could you describe the payment for Medicare Part B outpatient therapy provided in the home? If licensed as an agency, payment under Medicare Part A, under what type of a license is typically used to provide outpatient therapy in the home? and reimbursed under Part B.
So take the second part first, because that's an easier answer. I think you don't need a separate license. You can bill under your current home health agency license, because the Part B services are included in the home health conditions of participation. So no additional license is required. Payment is per CPT unit, procedural units. So it's a little bit different from what we're used to in terms of episodic care or even in per visit care. So for Medicare Part B, there are procedural codes, whether it be for an evaluation or for therapeutic exercise or neuromuscular reeducation. It just depends what sort of interventions you're doing with the patient that day. The CPT codes are billed in 15-minute increments. We can get into the minutia on that, but essentially, if you've done 8 minutes or more, you can round up to 15. So a typical treatment, it's going to be patient specific and based on patient need, but a typical treatment is 3 to 4 units, depending on what you've done with the patient for a treatment. I will add the caveat that there are a couple codes that are untimed. So the therapy evaluation code, it's a one-shot, lump sum for that visit, but the regular treatment codes are by CPT unit. So that is certainly, there's a couple different training points if you're going to have staff doing this. That is one that will be different for them to kind of keep track of which interventions they're doing and for how long, so that they can tag the correct quantity and type of CPT units for you to put on the bill. And for your claim, I use the standard UB form. It's a bill type 34X, place of services at home. So it looks pretty similar, at a glance from what you would use in home health, except instead of, your final claim is a 329 in home health. For this, it's a 34X. Place of service at home, and then instead of G codes, you have your CPT codes for what you're doing there. So hope that answers that.
Great, thanks a lot, John. The next question is for Maureen. So if we have a patient who requires skilled care under home health, but also palliative care, can you have both run concurrently, or must the patient be discharged from home health first?
They can run concurrently. So you would do your home health under Part A, and you would bill under Part B for your palliative care. We always also recommend that for palliative care, when you set it up and you enroll in Medicare Part B, that you have a separate NPI number so the billing doesn't get confused, because I have had clients try to bill for their palliative care, but they used their hospice NPI number and everything got rejected, saying you're hospice, you can't bill this. So we've been recommending a separate NPI number for the palliative care program, just to help alleviate. And a lot of times the home health and hospice MACs are different than the Part B MACs. So you want to make sure you know which one you're sending those Part B enrollments to and who you're sending those claims to.
Great, thank you very much. So the next question was about hospital at home. This asked, does hospital at home do visits prior to the patient coming home to determine if it is a safe environment? It's probably best to do that, to at least get that assessment done as much as possible. However, also, if you have a home health agency, if you're a part of a health system that you're doing hospital at home and you have a home health agency, it would be, you may want to communicate with them. They may know the patient, know what that environment is like, know what the obstacles may have been to the patient's care if you're not able to get into that environment. One of the things with hospital at home is look at all the tools that you have available. If you have a home health program, how can they help to support that hospital at home about the patients that they know and the resources available in the community that may be able to help that patient? But also, if you can, it would probably be best to have a look at that home to do that evaluation, to know, just from a therapy standpoint, are there a dozen steps that the patient must use to get up into their home, and then another 6 more steps to get to the next level where a bathroom is. How is that going to be overcome? What is the situation of food in the home? What is the situation for just general home safety? And having that assessment done prior can help to prevent readmissions and the patient coming back into the inpatient facility. So if it's at all possible, it's encouraged to do that, just to ensure that you're able to meet the patient's needs at home. And then our next question was, and this, I guess it could be for, I guess all 3 of us at one point, is there suspicion that once outpatient at home the services pick up even more ground, that Medicare will then start imposing more regulations and paperwork requirements? So this is geared towards that outpatient, but then as services grow, do we think there's like a risk for more regulations in the paperwork? So John, if you want to start with that, only because they did ask about that outpatient one, and then Maureen, if you want to speak to palliative, and then I can address the hospital at home.
Sure. I don't think there's anything, really looming on the horizon immediately, but certainly, anytime any program grows and utilization increases, it catches CMS's eye, and the regulation increases around it. Documentation requirements increase around it. There are some quality of reporting requirements in Part B for therapy. I suspect as we go down the road, it will become slightly more robust, so that we have more of an apples to apples reporting mechanism across different settings where patients receive therapy. But the short answer is no, there's nothing looming on the horizon right this second.
Great, thank you.
For palliative care, it's, if you set it up as a clinic practice or group practice under Part B, you're saying that you're pretty much a medical provider. So you're a doctor or nurse practitioner, depending on whether you can run your own practice as a nurse practitioner. So any changes they would make under that setting would apply to all physicians. So you would have to, they would have to actually pull out specific things. And the only place that I could see them doing is add more MIPS quality measures that would pertain to palliative care and symptom management, as opposed to right now there are, I think there's almost 200 different measures to choose from. You have to choose 6 every year, and you have to change those 6 every year. There are some that palliative care can apply, but if you're doing it in a different way, if you're doing it as part of hospice, if you're doing it under home health, yes, there's a chance they could start changing the way they define palliative care. Medicare Advantage plans are defining what they consider to be or palliative care and versus hospice care, and whether they're separating it out or they're still confused about it. So, and unless somebody defines palliative care and restricts that to being providers providing symptom management, they would have to make changes for all providers in this in-between world where
We might have froze. We'll give her a second to come back in there. On the hospital at home side, I mean, it's still a growing area. The COVID waivers kind of pushed it to the forefront. And if this is an area that will grow, it probably will receive additional scrutiny. But similar to the outpatient therapy, there hasn't been anything on the horizon to indicate there is going to be that increased scrutiny. Entities must submit a request to even be able to provide that. So that is one area in which CMS serves as like a gatekeeper there to make sure that entities are meeting all the requirements to be able to provide those services. But if this is an area that will grow, there probably will be more scrutiny, more outcome, more requirements for outcomes very similar to the inpatient one, which they must be met already at this time. But there may also be increased oversight then that Medicare is going to have a look at entities that newly get into that hospital at home field. So Maureen is back now, so I hopped in, but I'll let you finish your thought there.
I don't know when it cut out. So my last piece was, as long as everybody is defining palliative care as something different, there's always a chance government's going to come in and define it for us. So right now, there isn't any approach other than Medicare Advantages trying to define it for themselves.
Great. All
That's
right.
it.
Thank you. That's great. So the next question was for John was, do you need to secure any type of addendum with your payers to allow Part B billing?
So if it's traditional Medicare, no, you don't. Again, it's covered under our home health conditions of participation. You can bill Medicare, traditional Medicare Part B, just straight away. I will say that many agencies and clinics are expanding this service to other payer types. And if that is the case, then yes, you certainly want to go through whatever contract you currently have to see if they would cover this type of service. And if not, then pursue some sort of an addendum to be able to do this with a managed care, either a managed Medicare or commercial provider.
Okay, great. Thank you. The next question was for Maureen. Really, can a palliative MD sign for home health services?
As long as that MD is following that patient and knows the patient, my understanding is yes, that MD can be the attending or provider that's allowed to certify the patients. The nurse practitioner that's for that same palliative care program, if they're the ones seeing the patient, they can do that that face-to-face requirement. Some palliative care programs are becoming more and more primary care physicians or providers for patients, because a lot of patients we're seeing in many big cities especially, but in many areas, they don't have a primary care provider. So they're seeing all these specialists and then they get really sick. And so the person coming into the home, they want to become the primary care. It's not the way to start a palliative care program, but as you grow, you can make that decision. But as far as I am aware, yes, they can be the physician.
Okay.
For home health.
Great. So the next question was for John, and this is about, do you have to give the patients a good faith estimate like you do in outpatient clinics?
Yeah, so part of you're going to want to obtain a separate consent. So you're going to want to go through your admission packet and probably streamline it a little bit and have something that's specific for outpatient therapy so that you're able to provide them if they don't have a secondary insurance, they're going to have that copay, make sure that all of that is disclosed to them. So yes, you're going to want to do that for that patient.
Great. Thank you very much. And then another one, maybe it was answered for Part B and therapy. Do we need to have a separate MPI and a provider ID to start Part B and therapy under home health?
Oh, you can do it under the one that you currently have. And actually, without getting down too much of a rabbit hole, that's actually one of the advantages of doing this under your home health license, as opposed to like submitting a new 855 and creating your own outpatient entity. If outpatient clinics need to credential each of their clinicians with their own separate NPIs, whereas if you are providing the service under your home health license, you bill under your one home health NPI. So you just need the one NPI for your agency as opposed to having to credential each clinician separately with their own NPIs.
Great, thank you. And then while we're on the question of NPI, so for Maureen, if you're setting up a separate NPI for a palliative care entity, does it need to be set up differently per state, or can you use the same one in different states?
Good question. It depends on the state. So what I'm usually seeing is the NPI number is when you do your Medicare 855B for Part B billing, you have to say where you're providing services. Most states who require licenses for physicians' practices, if they do, not all of them do, you're going to need your NPI number to follow your license. So in that state, it's also probably a better idea to have a different NPI number if you have different states, just because states have their own rules about everything. The other thing in palliative care is different states have what is called the Corporate Practice of Medicine Act. It legally tells you who can own a medical practice. And when you're doing it as a group clinical practice, it's a medical practice and you have to abide by that Corporate Practice of Medicine Act. The states that don't have them are very lax. They just say, they're very lenient and just say you have to be able to prove a physician is actually managing the clinical components of this practice. In other states, they say a physician must own the clinical practice, and you can have an agreement for management services with a company, but a corporation cannot own a physician's practice. So you have to make sure you understand all the legal parameters about palliative care and physician practices as well.
Great, thank you very much. So I know we only have 3 minutes left. We've gotten a lot of questions. We'll get through as many as we can in the remaining time. For those that we did not, we'll go through and we'll respond to you as we can via email, because we'll have that from when you signed up. But if there's any questions that we didn't answer, you want to address something more specific, you can always find us at our website, SimiTreeHC.com. Feel free to reach out there for anything. We're happy to help out in any way. So for John, about Part B therapy, are there limits to the amount of therapy that can be provided in a given time period?
So no, but kind of yes. There are no hard and fast limits. You might have heard about something called the therapy cap. So there are sort of fuzzy limits on the amount that you can bill a Medicare beneficiary under Part B in a given year. It's different for OT versus PT and speech that get lumped together because somebody forgot to use an Oxford comma when they were writing the legislation. That's a whole other ball of wax that we could get into some other time. But there are dollar limits on what you can bill straight away. If you exceed that limit, you put a modifier on the bill and you can go beyond that. If you routinely exceed the limit, if you will, you will still get payment, but you're going to increase your exposure for like a review, essentially an audit by CMS, to make sure that the services that you're providing are reasonable and necessary. So there's not really a hard and fast limit, but if you exceed the limit that they have created prior to having to add a billing modifier, they're going to come take a look at what you're doing to make sure that it's all medically necessary and clinically supported in your documentation.
Great, thank you very much. So I think we have time for one more question. This one is, where's the best place to review the rules and regs for Part B? CMS.gov is a great place to start, and we can share that out as well. But Maureen or John, are there any other places or resources you'd recommend.
So on the therapy side, if you want to cut right to the chase, the sort of the gateway to all of this is in our home health conditions of participation. It's under the organization and administration of services section, which is 484.105. Within that COP, you want to look at section 2G. That's the one that talks about billing Part B, and that piece of the regulation in turn references the other conditions of participation or requirements that you need to satisfy around plan of care, definition of PT and speech, environment of care, emergency preparedness. I think that's all of them if memory serves. But really, a 44.105 2G is really the part that you want to go to.
Great, thank you. And Maureen, how about for palliative care?
For palliative care, CMS website, the American Medical Association, because they are obviously in charge of physician practices. CAPC, it's the Center for the Advancement of Palliative Care. They're based in Florida. They have tremendous information. You have to be a member. I don't remember what it costs, but you can only be a provider to be a member with CAPC. And then there's NHPCO and NOC, who also have some really good information on their websites. A lot of the information in NOC and NHPCO you can get without being a member, but then there's more in-depth information once you're a member, your organization is a member. And us, SimiTree.
Yeah, SimiTree. Thank you. For the hospital at home, there's qualitynet.cms.gov. They have a great just overview, some FAQs in there. They'll have information on the waivers. That's really the go-to place if you're looking for the hospital at home piece. And like Maureen had said, SimiTree, feel free to reach out to us with any questions. Right now we're a minute over. I just want to say thank you to Maureen and John for joining me today. This was a really great session. Hopefully we answered a lot of your questions. Thank you to everyone that took part in this and for all of the cool questions. For those that we did not get to, we'll reach out with a response as we're able, and this recording will be sent out in the next week. So thank you again. I hope you all have a great rest of the day.
Thank you.
Thanks, Charlie. Bye, guys.
Bye.
Bye.